So the topic of today's lecture is the principles of antibiotic therapy, and we are starting a new section that is dedicated to the antibiotic therapy, and the drugs that we will discuss in this section are a little bit different, and that is why I will shortly introduce you to the specifics of the antibiotics and what you should know, additionally to the common properties of the drugs to be able to select the best antibiotic for the current disease, and also take into account the different properties of the antibiotics, including the spectrum of action and also potential for interaction, and also the duration of the therapy, and many other specific choices. And the selectivity of the antibiotic is based on the differences between the structure of the human cell and the bacterial cell, or the other microorganisms, including the viruses but we mostly will focus on bacterial cells, because antibiotics are only used for the treatment of the bacterial diseases, and after that we will also learn the other types of the chemotherapeutic drugs, including ones for the viruses, for the cancer, and for other diseases. So and we will start with the bacteria, and all the antibiotics are divided according to their mechanism of action, and there are 4 mechanisms of action for the bacteria, and so this is a cell of the bacteria, and the first mechanism of action is the inhibition of the metabolism and a conversion of the para-aminobenzoic acid to the tetrahydrofolic acid. And because the cell wall of the bacteria is not permeable for the para-aminobenzoic acid, bacteria have to not permeable for the folic acid, the bacteria have to produce folic acid from the para-aminobenzoic acid. So, and that process is inhibited by the sulfonamides and trimethoprim, and these are the one small group of the antibiotics. But not the mainstream actually. So the first antibiotics were the inhibitors of the cell wall synthesis, and so they inhibit the synthesis of the cell wall of the bacterial cell, and because the human cells don't have the cell wall, then that makes it a selective action, and actually the cell wall of the human cells is permeable for the folic acid. That is why the humans don't synthesize folic acid, but consume it from the food instead. So, and also that also makes a selectivity. So, and the drugs, the antibiotics that inhibit the cell wall synthesis include beta-lactam antibiotics, and that includes penicillins, cephalosporins, carbapenems, and monobactams. And we will start with the beta-lactam antibiotics next week. Then also vancomycin and other mycins, that adaptomycin, telavancin, and fosfomycin. So these are the antibiotics that inhibit the cell wall synthesis, the second mechanism. So the third one is inhibition of the protein synthesis, and the traditional is the tetracyclines, including the tetracycline itself and its derivatives, doxycycline, then aminoglycosides, macrolides, and clindamycin, chloramphenicol, and linezolid. So these are the protein synthesis inhibitors that inhibit the synthesis of the protein on ribosomes, and you will argue that the humans have also ribosomes. So why it's selective? It's selective because the size of the ribosome in the bacterial cell is different from the size of the ribosome in the human cell, and that is why there is a selectivity of these antibiotics. However, the mitochondrial ribosomes are have common size, so that is why it's not selective against mitochondrial ribosome, and that is why there are some adverse effects more than with the beta-lactam antibiotics and the previous group. So, and the fourth but not the least one, these are the inhibitors of the nucleic acid function or synthesis, so DNA, so RNA synthesis inhibitors, and these are actually the only one group of fluoroquinolones, and rifampin, actually used for the treatment of the tuberculosis. So this is the most advanced group and usually has a broader spectrum of action. So, and also the DNA of the bacteria is different, so that is why there is a selectivity for these drugs. And also inhibition of the cell membrane function, including the isoniazid, amphotericin B, and polymyxins. This mainly used for the treatment of the tuberculosis with the isoniazid that is actually because the cell wall, because the cell membrane of the mycobacteria has a mucolic acid, and synthesis of the mucolic acid is inhibited. So that is why there is a selectivity of these drugs. So these are the classification by the mechanism of action. There is also a classification by the chemical structure, like for example beta-lactams and the tetracyclines, but then it's not very much useful for the pharmacology, and that is why most of the time we will use the classification by the mechanism of action. And also there is a classification by the type of the organisms that drugs will act on. So this includes the bacteria, like these drugs, and also the fungi and viruses, and also protista and other worms. So and this is actually the classification. So now when we are familiar with the drugs and with the classification, then we can step into the selection of the antimicrobial agents, and also uh, the basic principles of uh, how to manage the antibiotics, uh, and to select the antibiotics, one should know what is the disease, what is the bacteria that invades the organism, and also the susceptibility of the bacteria to the particular antibiotics, and also the site of the infection, and also the patient uh, patient factors and safety of agent. And in recent years, it's also uh, we need to also consider the cost of the therapy, because uh, recent the newest antibiotics uh, price can be as high uh, as the cancer therapy, so that is why the cost is also important. And sometimes there is no time for the identification of the bacteria, and then the patient will be treated empirically, so by uh, prescribing uh, the most with the some antibiotic with the broadest spectrum of action. So, but usually the first stage is to identify the infection, and and usually the identification is made by the gram stain. That is very useful for identifying the morphological features of the microorganisms, and the but to be able to identify with the gram stain, we have to obtain a culture uh, for the growing the organism, and after that, after obtaining the culture, the patient can be prescribed antibiotic for the empiric therapy, and the culture can be put to the growing uh, and that usually takes several weeks, and then we can uh, we can make uh, we can test for the sensitivity of the microorganism to the antibiotics. So but sometimes there is no time for all of that, and then the patient should be started treatment immediately. So usually it's just right after the taking the material for the culture, and usually the empiric therapy is based on the site of the infection, and choice of the antibiotic may be guided by the clinical setting. So and and also the age of the patient, or the some information from the patient, like if he was traveling recently, or if he is working with the animals. So And for example, if patient was traveling from some endemic uh, country for specific disease, for example, patient is traveling from India, and the malaria is very common in India, so that is why if you see a patient with a high temperature and is actually very severe disease, then probably first you have to check is for the malaria. So and for example, if your patient is a newborn, and then and you see a gram-positive copy in the spinal fluid of a newborn, so it's probably the Streptococcus agalactia, that is the group B streptococci, and is sensitive to the penicillin. So you can prescribe a penicillin G, that is actually a short spectrum antibiotics and very cheap. And if you see a gram-positive copy in the spinal fluid of a old patient, that is probably Streptococcus pneumonia, and, Streptococcus pneumonia is very resistant to the penicillin, and that is why you have to prescribe something like a cephalosporin, preferably third generation, that is injected intramuscularly, something like ceftriaxone or ceftazidime. Uh, so that is a broad spectrum antibiotic, and will not and it doesn't have resistance to the Streptococcus pneumonia. Then so you after the starting of the empiric therapy, uh, and also after the taking the uh, medium uh, for the lab from the patients, it can be the blood, the sputum, the skin scrub, depending on where the infection is. Uh, the In the lab, they would determine the antimicrobial susceptibility of the infective organism, and this is usually done in the culture with the several specific antibiotics, and they uh, they also can calculate the minimum inhibitory concentrations of a drug, and the antimicrobial drugs can be divided to the bactericidal and bacteriostatic, and bacteriostatic drugs stop the growth of the uh, microorganism, and but they don't kill them, and that limits the increase of the number of the bacteria, and this rest of the bacteria uh, will be killed by the immunity, like the macrophages, and uh, so macrophages will actually consume the rest of this bacteria, and um, bactericidal drugs will kill the bacteria, and the number of bacteria will drop with a very small amount, and the immune system still have to clean them completely, but still it's easier. And this is very aggressive action, and bactericidal agents are often drugs of choice in the uh, patients with the immunocompromised uh, tissue, so in HIV patients and also in the patients that take immunosuppressive agents for the transplantation of the body or after the transplantation. So all patients taking uh, the glucocorticoids that suppress the immunity. And um, so this is actually the two types of action. So the penicillin is actually, for example, is bactericidal, while chloramphenicol is bacteriostatic. And usually you don't want to combine these simultaneously in one patient at the same time because they will reduce the effectiveness of each other. Um, so the next thing is the minimum inhibitory concentration, that is the lowest antimicrobial concentration that prevents the growth of an organism. And this way we can measure the susceptibility of the bacteria to the antibiotic, and the antibiotic with the lowest concentration will be most effective. So, and the same is for the minimum bactericidal concentration. That is for the bactericidal antibiotics, and the bactericidal concentration is the lowest concentration that it results in 99.9% decline in colony count after the overnight. Uh, so and also the if the infection is in the brain, the so that the bacteria is colonizing the brain, then the antibiotics should pass through the cerebral uh, through the blood-brain barrier, and uh, and so not all the antibiotics will pass the blood-brain barrier because uh, the tightness of the junctions, and so only small and lipophilic molecules can pass the blood-brain barrier. And the passing is usually influenced by the lipid solubility, and lipid-soluble antibiotics like chloramphenicol and metronidazole can penetrate into the central nervous system, while penicillin, that is ionized and have low solubility in lipids, it can't pass. That is why the penicillin is not used for the central nervous system diseases, and most of the meningitis will not be treated with the penicillin. Even though the permeability is of the blood-brain barrier is increased while during the inflammation, um, but and that will allow penicillins to enter the cerebrospinal fluid during the inflammation. Once the inflammation subsides, the concentrations of of the penicillin will also decrease, and that will stop the treatment. That is why it's not recommended to use the penicillins or any other drugs that don't cross the blood-brain barrier without inflammation. So, and also the low molecular weight drugs can pass better, and that is why, for example, vancomycin is not penetrating the blood-brain barrier, and also the drugs that bind to the protein will cause less, because they there is not so much unbound drug in the blood. That is why it will not pass alone. And while selecting the antibiotics, we also have to take into account the patient factors. For example, the immune system, kidney, liver, the age, and also the sex of the patients, because women can breastfeed and also plan the pregnancy, and all antibiotics are contraindicated for the pregnant woman, and all of them will be secreted to the breast milk. And the first thing is the immune system, and immune system is important for the elimination of the bacteria, and alcoholism, diabetes, HIV, malnutrition, autoimmune disease, and pregnancy can affect the immune system of the patient, and also the immunosuppressive drugs that are used in HIV can affect, and that may require the high doses of the bactericidal agent and longer courses of the antibiotic treatment for the elimination of the disease. So because the antibiotic have to kill every organism, every bacteria, so that is why the treatment will be longer, so everything up to 0, because usually the antibiotics will kill almost to 0, but they will remain a little bit, and that a little bit will be managed by the immune system. So the second thing is renal function, and poor kidney can accumulate antibiotics, and in those patients we have to adjust the dose, and that actually is important in the elderly patients, because they are very vulnerable to the elimination by the kidney. Then hepatic function is also important, because there are antibiotics like doxycycline, for example, that are eliminated by the liver. So liver dysfunction may increase the doses. And then also perfusion is important, for example, in diabetic patients, that can decrease the efficiency of the treatment. And then also the age is important, because the renal and hepatic elimination decreases in elderly, and also is poorly developed in newborns, and that is why these patients can be vulnerable to the antibiotics overdose, and also the young children should not be treated with the tetracyclines and quinolones, because they affect the bone growth. So for example, tetracyclines are contraindicated up to the age of 18 for the ointment, and up to the age of 14 for the tablets. And then also pregnant and breastfeeding mothers cannot use antibiotics because they cross the placental barrier, and they can enter the infant via the breast milk. So then also some infections can be resistant for the antibiotics, and then this actually maybe prolong the treatment, especially in immunosuppressive diseases. So when initiating the therapy, the safety of the antibiotic is very important, and the most non-toxic, the most safe drugs or safe antibiotics are the penicillins, and less safe is chloramphenicol, is most non-selective, so most toxic in the patients. So toxicity is actually important, so that is why most physicians prefer the penicillins, especially the pediatricians. And the last but not the least is the cost of the treatment. And when we have a similar efficiency drugs for the same infection, but the cost is higher for the one, then it's better to select the lowest cost, and so to save the money for the patient. So so actually this is the cost for the treatment of the Staphylococcus aureus, that is very common pathogen. So and all these drugs have the same effectiveness, like cefazolin is actually cephalosporin, that is a beta-lactam antibiotic, so it's the cheapest one. Then linezolid and daptomycin are the most expensive ones, so that is why clindamycin is like somewhere in between. So and we should choose a cefazolin in that case because it is most effective, cheapest, and also does not require any special permission for some, because for example daptomycin requires permission from CDC in some countries and is not available in every setting. And then there is also some cases when we can use antibiotics for the prophylaxis. So, and there are only 4 cases. So for any other reason, the antibiotics should not be used for the prophylaxis. Unlike the most other drugs, antibiotics are not effective for the prophylaxis. So what exceptions are the prophylaxis of the heart disease rheumatic heart disease that is caused by the streptococcal infections. So, and then the second is the prophylaxis for the surgery, mostly dental removal, for those who have implanted prosthetic devices such as artificial heart valves, that is to prevent the seeding of the prosthesis, but also this can be used for the prevention of the seeding of the valves themselves. So for these purposes, usually broad spectrum antibiotic is used, like for example amoxicillin, about several hours uh, before the visiting uh, the dental cabinet. So can be introduced 12 hours before, and a pretreatment uh, of the tuberculosis and meningitis in the relatives of the ill patients, so in patients ill with tuberculosis, and also treatment to the surgical procedures, usually for the sterilization uh, of the uh, uh, of the GI, and mostly intestine before the surgery for the intestine, or for eradication of some pathogens like, for example, Helicobacter pylori during the ulcer. So these are actually the prophylaxis use of the antibiotics. So do you have any questions?
I don't think so.
No question? So if no questions, then I think we can uh, continue with the practice. So let's make a small break, and then we will continue.